talks and the learning opportunities that we bring in the fall from the opportunity and belonging. And we have Dr. Aponte here today. So glad to have him, and I will introduce him a little more after we have our opening from Dean Boskamp.
Well, thank you, Mekbib, and glad to have everybody here. I'm seeing one Yankee jersey after a big 3-run shot from Judge last night that sort of has energized everybody. So we'll see what happens in the Bronx tonight, but good move with the jersey. Yes, that's the new dress code. And all right, don't take it off, even at night. But really glad to have Dr. Aponte with us today to celebrate Hispanic Heritage Week. And we're really happy for that. And I think as all of you live and breathe our Human Dimension course, his involvement in the community is something that we're trying to get all of our students to aspire to. And so I know he's going to have, a really inspiring message from his own career. And what a wonderful title on this, by the way. I love that. And Mekbib shared with me stories that I won't do spoilers about, but he grew up in the neighborhood and then dedicated his career to giving back. So there's no better message, I think, that all of us, faculty, staff, and mostly students, could get from this. So we were just talking. For those of you that don't know, I live in West Harlem. He lives in East Harlem, but not far. And he and my wife both went to City College, which is right near where I live. Go Beavers, right? Yes. At any rate, it's a pleasure to have you here. Thanks for coming out, and looking forward to your talk today. Please welcome. Well, you're going to, hold on, don't welcome him yet. There's a much better introduction coming.
Not much of an introduction because I know Dr. Aponte would talk a little bit about his journey, but I just want to give. I had the privilege of knowing him for a long time throughout his career, and he has really been an exemplary leader in various settings. In academic medicine, he was a leader at Mount Sinai School of Medicine as well as Zucker. And then he moved into the hospital and healthcare leadership, where he was both, chair of pediatrics and medical director at North General, and then later at United Health. And then he moved to his the first love, which is community health, where he was chief medical officer at Brownsville Community Health Center. And then, finally, he went back home to East Harlem to be CEO of Borican. So it is really, so important to get his insight, both in terms of, the context of care and education that he can think of. Because we do talk and we do intentionally guide students to think about community health and how you engage with communities from the start. But there isn't really an instruction of how to do that. And so this is like a really important and interesting context to bring to do, how do you get back to that love and what does that look like? And I know he will talk a little bit about the systems, but he would talk more about the heart and the journey that he was involved with. So thank you for being here. It's wonderful to see you, and we are looking forward to your talk.
All right, can you guys hear me? Good afternoon. I said, can you guys hear me? Good afternoon. All right. There's at least 20 people or so here. You guys did not take my invitation to come up, so I can't see you back there. I just had PRK, if you guys know what that is, but I had LASIK surgery, so I can't see any faces back there. So if you raise your hand or you're interested in interacting, I won't know. Anyway, Dean, thank you so much for inviting me. Of course, McBeeb, it's great to reconnect. We've had a lot of stories to share, McBeeb and I. We've done a lot of road trips together in the work that we've done, so I'm happy to be here. It's been a while since I've been in front of medical students. I used to do a lot of work with medical students when I was a dean at the medical school, but have been removed a little bit from that, but still very involved in some of the work that we did there that I'll describe. So I have a slide deck. I can't promise that I'm going to stay on slides because I tend to veer off a little bit. And I want this to be more of a discussion and dialogue than me just standing here talking. Because I could tell stories, trust me. But I'd rather really have an engagement around the kind of work that I'm doing now, the kind of work that I think is necessary for communities that I serve, and really the changing landscape that you guys are all sort of going into in terms of medicine. It is a very interesting time for us in this country, particularly for communities that I serve that are underserved, Medicaid populations, and the challenges that we're going to face with some of these things that are occurring at the national level. So anyway, we'll talk a little bit more about that. Want to tell you a little bit about myself first, and then we'll get to some sides. But as McBeeb shared, Adam Aponte, born and raised in East Harlem, New York. Parents are from Puerto Rico. Where my Boricuas at? I got one or two? All right, pa que lo sepa. And, you know, and I'll try to make this story short because it's a long story. Despite my youthful appearance, I've been doing this for a minute. But grew up in East Harlem with this daring dream to become a physician from very, very young. I was that kid that, you know, 4 or 5 years old, I knew I wanted to be a doctor. And from my Puerto Rican families here, you know, I was a large family. I'm one of 7. I'm number 6 of 7. And in a Puerto Rican household, we do a lot of partying. We don't need a reason to celebrate. And so, you know, each time we had celebrations, my house was a gathering place for some reason, even though it was way smaller than this room, this auditorium here, the entire apartment. So you can imagine growing up in tenements in East Harlem. And inevitably, during the course of the time when we had a party, my father would stop the music and say, hey, everybody, guess what Adam wants to do when you grow up? What do you want to do? I said, oh, I want to be a doctor. I said, hey, que bueno, que bueno. That means very good, for those of you who don't speak Spanish. So it was one of those things that sort of, you know, further sort of affirmed my desire, but there were other things that drove me. And hopefully there are things that drive you to be in this field of medicine. And why? What's your why? You should all know what your why is. And my why was certainly, you know, seeing what we now call health disparities that exist. You guys should all know what that is. And clearly I had a very bird's eye view of that because I grew up in East Harlem, right next to a community called the Upper East Side. You guys know the Upper East Side, right? One of the most affluent communities in the country, probably the largest concentration of millionaires that you will find. These two communities sit right next to each other, divided by a yellow line that we call 96th Street, right? 96th Street runs east and west. And when you're on this side of 96th Street, the south side, you're in Upper East Side affluent community. All you do is hop like this, and you're in East Harlem. And everything changes. Like literally everything changes. Zip code changes, 10128, 10029. Police precinct changes, 19th precinct, 23rd precinct. And then when you look at all the health indices that we look at, they all drastically different. You know, as I'm a pediatrician, I think you guys know that. So one of them is, and I didn't know this then, right? But I just knew that people in my hood were not having the same outcomes as people on that side of the street. It was very clear and evident to me, right? So that was one thing. But, you know, just to drive that home further, the division between these two communities, served by the same hospitals, right? Metropolitan Hospital, Mount Sinai Hospital, Lenox Hill Hospital, Harlem Hospital, North General, as Dr. Gameda pointed out earlier, was another hospital. Unfortunately, it's closed, but the hospital there, surrounded by these two same hospitals, right? So you would think they have equal, quote unquote, access to care. Yet the outcomes of these two communities are disparate by all measures. And one of them I tend to opine upon is infant mortality. You guys know what infant mortality is? What's infant mortality? This is going to be interactive. I'll come stand next to you if I don't get some interactions. But who can tell me what infant mortality is? Anybody? All right, so I got to pull a little bit from you guys. I'm gonna have to work this room a little bit, it seems. Okay, I got it. I got my assignment now. So infant mortality, for those of you who don't know, is a child dying within the first year of life, right? So any child who dies for any reason within the first year of life, we track that and we refer to that infant mortality. Obviously, there's numbers of reasons why children die in the first year of life, some congenital defects, heart defects, you name it. But, you know, we've been working as a country to really reduce infant mortality rates, right? And we sort of do this per, 1,000 children born. And, infant mortality rates at the turn of the century, turn of the previous century, 1900s to whatever, was 25, 30, malnutrition, childhood vaccines, of course, all these childhood diseases that this person in the let me not get off on a tangent, but vaccines work. And they should be provided to all children. But in any event, right, we reduce infant mortality rates drastically. So now, you have places that infant mortality rates of like 5, 6, 7. So East Harlem, Upper East Side. Upper East Side, infant mortality rate is about 3, right? We're gonna cross that double yellow line again. We're in Harlem, East Harlem now, it doubles. So all we did was cross from one side of the street to the other, and infant mortality rates have increased, right? And the question that we should be asking is why? If we truly have equal access to care, why are these outcomes different? Same thing for pediatric asthma, hypertension, cardiovascular disease, diabetes, you name it. So that was a driving force. I recognized that as a young person that, people in my neighborhood were dying younger. So that was one thing that drove me. The other one was love of science. I love that science. I was that kid who watched all the PBS shows and watched Nature and just really was fascinated, as I'm sure you guys are now, just like with the ability of the human and what we've evolved to and the human brain. We haven't even tapped into our full potential in terms of the human brain yet, right? But amazing things that we can do as far as just science. So that was very intriguing. And the other one, if I'm being very honest, and I think we're all adults here, it was kind of my badassness. And what I mean by that is society said a kid from East Harlem, Puerto Rican kid from East Harlem, would not amount to becoming a physician. I was like, oh yeah? Watch. And that was something that really drove me as well. And now I can't say that I did that with overwhelming confidence because society messages a lot to you, right? Society tells you a kid like me would not become a physician, right? My surrounding community did not support that because there were no doctors in my neighborhood. Right? The only people in the pharmaceutical industry in my neighborhood were not people you want to hang out with. So 3 people got that. The rest of you are like, what's he talking about? Right? But we keep it 100 here, right? Those are the drug dealers, right? And in our neighborhoods, there was a lot of those. And while I never supported, condoned, or participated in that type of lifestyle, you can understand why young men in particular in East Harlem who are in this deep valley don't see any hope, don't see a way out, might gravitate to that young brother on the corner who's got that water cash, he's got the bling, he's got the car, he's got the girlies around him. That's what's up. You're like, yo, that's my way out. And unfortunately, so many of my friends went that route, but we know what the outcomes of that lifestyle are, right? There's usually 2 outcomes. You wind up in college. What's college? Prison. That's the affectionate term we use in the hood for prison. Or you wind up in a nice green valley where people come out and visit you. That's the cemeteries, right? And so clearly that's not a route that I want to take. And I think maybe I was too much of a, I was pretty bad when I was a kid, but I wasn't that bad in terms of that kind of lifestyle. So, so that was something that, there were no role models to sort of gravitate towards, but it was something that I knew I wanted to do. So I went on this whole journey of going through medical school and going through public school systems in New York, and despite obstacles, despite challenges, despite naysayers. And I'm not sure if you guys have had any naysayers in your life, but there are people, and you remember these individuals, the people who really support you, and those people who try to really detract from your dreams, right? And so I often talk about my 9th grade teacher, Mr. Ambrose. He doesn't like when I talk about him. You know why? Because Mr. Ambrose asked me at 9th grade, Adam, what do you want to do when you grow up? I said, well, Mr. Ambrose, I want to be a doctor. And he looked at me very oddly, because he was an oddly looking person, and said, oh, perhaps you shouldn't aspire so high. And I often joke, I was like, I'm not even sure I knew what aspire meant. But I knew one thing. I knew he wasn't supporting my dream, right? And here is an educator, someone charged, responsible for my education, right? That should be nurturing, pushing me, supporting me. Here, this person was dismissing my dream, right? And so many students face that. That's why Dr. Gameda and I have done all the work that we've done with these pipeline programs, because we know many students experience Mr. Ambroses of the world, and they get detracted. Had I listened to Mr. Ambrose, I wouldn't be here today, right? So, by the way, fun fact, fast forward many, many years later, Mr. Ambrose became the principal of that school, and he invited me back as one of his star alumni. Myself and someone who you guys may know, Malik Yoba, if you guys know Malik Yoba, New York Undercover, Why'd I Get Married, Cool Runnings. Does that resonate with anybody here? Google him, damn it. That's my boy. We know each other since second grade. At the time, he was on a very popular show in New York called New York Undercover. And so they invited us back, and, of course, being who we are, with like, Malik says to Mr. Ambrose, do you remember when you told Adam not to aspire that high? And he turned all red in the face, like, I didn't tell you that. I said, yeah, you did. And we said it in front of his students. And so now you got the principal like, all right, well, anyway, so that was a journey. And I share that because those are the challenges that many of us face to get to this point in our lives. And it doesn't stop there, unfortunately. And, I can go on and on about my journey into medical school and getting where I was. I don't believe in luck. I think everything happens for a reason. I often tell students luck is preparation meeting opportunity. There's going to be opportunities out there that you prepare yourselves for. Obviously, you guys are successful. You've made it to medical school, so congratulations. There's definitely still a longer road ahead of you. And hopefully the Mr. Ambrose of the world will disappear and we nurture everyone's dream, whatever that dream may be. I don't care what it is, right? I'm a pediatrician. I don't see patients now, unfortunately, because I'm more of an administrator now. But I remember seeing patients. And every kid who comes into my exam room, I would ask them, what do you want to do when you grow up, right? And, this happens all the time. If you're in pediatrics, they start off with like firemen and police officer, and then they become sports and, whatever. But I don't know who the next Michael Jordan is. I don't know next who LeBron James is, who the next Aaron Judge is, right? So when they come to my exam room and they say, I want to be a professional basketball player, professional football player, whatever, I support that. I encourage that. Now, it's easier to become a doctor, quite frankly, than to become a professional athlete, but you never know who that kid's going to be. But then I encourage them about what you need to do to get there, right? And you guys all have done that. You put in the time, the education, the dedication, the sacrifices, right? We all missed a few parties during college that we wanted to go to, but we had to do the things we need to do. So that was my journey. And then, I tell people I have so much gravy on my plate. Like where I am now today serving, and you're going to hear more about it, is way beyond even my dream. And I thought I dreamed big. And so, I just thought I was going to be some doctor in the hood, taking care of my patients one-on-one. And then I was very blessed and fortunate to have good mentorship, was encouraged to seek leadership opportunities. And now today I sit running a health center in the very community that I lived and grew up in. Like I can literally see the place where my father worked 3 blocks away from my health center, right? So I spent all my life there, so I feel very privileged and honored. So what I run is called a Federally Qualified Health Center. I'm going to tell you a little bit about that. Let's see if this thing is working. Do I need to point it somewhere? Am I pressing the wrong button? Is it on? I was pressing the wrong way. Okay, so a few things here I want to go over with you guys just to give you a sense of the work that we do. How many of you guys have heard of Federally Qualified Health Center? Raise your hands. Okay, very good. So about half the group, good. So you guys will know more about it. So these are some of the things I want to go over with you guys. We're going to get into, I think, a little video, and Jesse's going to help me out here just in case I don't do this right. I just hit return. Nope, I got to go back. Yes. So just take a look at this and then.
It began nearly 60 years ago as a bold experiment in health equity. The goal was to bring doctors to America's most overlooked rural and urban communities, areas that mainstream medicine ignored. With roots in both the civil rights movement and the war on poverty, The earliest health centers had as their mission no less than using the healthcare system to change lives. The first health centers were launched in Mount Bayou, Mississippi, and in Boston, Massachusetts. From there, a revolutionary partnership began with determined doctors, nurses, community leaders, and the federal government to build a community health infrastructure that turned no one away and reached beyond the walls of the exam room to not only prevent illness, but also address the social drivers that cause poor health. That small investment has saved countless lives. The program survived and grew despite many challenges, with health centers coming together to speak with a collective voice to decision makers in Washington. Today, health centers are the largest and most successful primary care network, serving more than 31 million people nationwide. They have earned bipartisan praise for their groundbreaking work to break down the barriers of care, reduce health disparities, reduce ER visits and hospitalizations, and lower healthcare costs. Health centers treat the whole health of each patient with services that include primary care, pharmacy, oral health, behavioral health, and enabling services. They are frontline responders to America's greatest public health challenges, such as natural disasters and a devastating global pandemic. They are heroes, innovators, and troubleshooters. Community health centers are the best, most innovative, most resilient, and most diverse part of America's healthcare system.
Right, so that was produced by the National Association of Community Health Centers, NAC, they put this video together. It's actually a couple years old, so I'm gonna update some of the data on that, but just give you some context, right? So this is, we've been around for a minute, as we like to say. Am I good? So this is a little bit of the history. We went over a little bit, but just as a reminder, so FQHCs, also known as community health centers, very commonly known as that. Not that every place that you see that says they're a community health center is necessarily FQHC. It's a designation that we receive. Again, war on poverty, for those of you who are familiar with that, 1964, a little bit before the time of most of you in this room, right? But it was that war on poverty during the Johnson administration. A couple of programs came out of that. FQHCs were one. The other one I mentioned because we run one is bilingual Head Start programs. So Head Start program started in the 1964 war on poverty as well, and we run one as well. So I'll share some information about that. The first two are still in existence. So Mount Bayou in Mississippi and Columbia Point in Boston are still existing FQHCs. Those are the very first two that were created. By the way, the picture that we saw before was Dr. Jack Geiger. Have you guys heard of Dr. Jack Geiger? So he's known as the father of FQHCs to us. He just died, I think, about 2 years ago, but this is a guy who really spent his whole life, literally, focused on underserved communities and making sure they had access to healthcare, and did tremendous, tremendous advocacy around that. So we really credit a lot of this movement, and we call it a movement, to Dr. Jack Geiger. So these are the main goals, serving the underserved, regardless of anyone's ability to pay. You walk through my door, I see you. I don't care about your immigration status. I don't care about your ability to pay. I don't care who your insurance is, race, ethnicity, sexual orientation. Nothing matters to us except that you walk through our door, and we find ways to take care of you. Right, so that's something very unique about FQHCs. So when someone ever asks you, where can I get care? I don't have insurance, point them to FQHC. We will see them. Now, there's some threats to that today, but we'll get into that maybe a little bit later. But that is one of the original goals, is to reduce the barriers to care that people experience, including financial barriers. And our focus is primary and preventive care, but you'll see or you hear about our health center. We do some specialty care as well, and there's a reason for that. But the real focus is quality primary and preventive care services. And we know that when people get great primary and preventive care services, a lot of things down the road can be avoided, or at least, somewhat eliminated, or perhaps delayed, if you will, depending on what conditions people sort of get as they get older, chronic conditions. Today, there are actually over 1,500 FQHCs in the country. And there's something called lookalike. Lookalikes behave very similar to FQHCs. The big thing is that they don't get federal funding, but they have the same mission in terms of seeing anyone and working in underserved communities. We have a total of 17,000, almost 18,000 sites across the country. And they serve now 34 million Americans. That means 1 in 10 people in this country get their care in a federally qualified health center. That's pretty significant. Now, we're not one network. We don't all work together, but we all work in a similar fashion. We have, we're all under what's called HRSA, the Human Resource Service Administration, in terms of funding. Our guidelines, what we're supposed to do, all come from HRSA. How we deliver that in each individual community may be a little different, but the philosophy around all FQHCs is very, very similar. But you think about it, 1 in 10 Americans get their care there. So who are the patients that we serve? Again, in 2024, it was 33.9, 34 million. This includes 1 in 9 children. Remember this, when you do animations for slides, you got to time this because like I'm pointing and it's not going. More than 24 million Medicaid, Medicare patients, 9.6 rural residents, so rural America, a lot of them. And sometimes the FQHC is the only healthcare provider in some parts of rural America. And I say that, I want you to remember that point because when we think about HR 1, this bill that was just passed, and some of the implications of that bill, some of these communities that have nothing else but an FQHC are going to be harder hit than places like New York City. And I think that that was very short-sighted in terms of this bill. You'll never hear me call it a big, beautiful bill because there's nothing beautiful about it. And if I'm getting too political, I'm sorry. But let's keep it 100. That was a terrible bill. Homeless populations, there are actually some FQHCs that are dedicated solely to homeless populations in certain communities. And then agricultural workers, a lot of migrant farm workers, actually a lot of migrant backstretch workers. Do you guys know what that is? So people who work the racetracks of New York, of this country. They're very similar to migrant farm workers, and they go from racetracks to racetracks based upon the season. And I learned about them because in New York, we have Belmont, and I was doing some work there with some students, and we learned about these backstretch workers who are, I mean, the working conditions that they're under is horrendous. And they travel, most of them are undocumented. They follow the horses throughout the country, and they serve these horses. They do all the grunge work, dirty work, very dirty work. The horses get treated better than these workers. That's a fact, right? And so it's a very interesting population. And then school-based health centers, we do that, a lot of work in school-based health centers, and then veterans. We actually take care of some vets as well. Usually most people live below the federal poverty line. Do you guys know what the federal poverty line is? So for an individual, single household, the federal poverty level in this country is about $15,650. So if you're at that level, that's the federal poverty level, right? And then it increases about $650 for each additional individual. So you could do the math in terms of family of 4. Most of the individuals that see us are 200% below that poverty line. So if you're a single person, you're making less than $31,000 a year. But then strikingly enough as well, there are also about 70+% that are only at 100% of the federal poverty line. So you can imagine the conditions. One-stop shopping, I'm going to try to go through this quickly, but again, the animations, I'm just going to keep clicking. You will see all the services that we do, but it's a one-stop shop. You come into our building, we surround you with services. We do everything we can to give you everything in one building. Why? Because this healthcare system of ours is very complicated. It's very difficult to navigate. And I'm not sure if any of you have experienced personal health issues such that you had to go to many ologists, right? Or if you have family members who have experienced health illnesses that cause them to see various specialists. I'm sure you've seen how challenging it is, even for those of us who are well-resourced, to navigate this healthcare system. So you imagine someone who's a recent immigrant, imagine someone whose English is a special second language, right? It's a very intimidating process as well. As much as I love my profession, some of my colleagues are arrogant. Some of them are pretentious. Some of them think because all the degrees they have on the walls, that gives them the right to talk to people in a certain way. And I'm sure you guys are being taught differently here, right? It doesn't matter what degrees you have on the wall. It matters how you treat people at the end of the day. Not one single patient has ever asked me what college or medical school I went to because I'm treating with dignity and respect. Now, amongst each other, we'll say, well, I went to Mount Sinai, and I went to Einstein, and I went to Cornell. But who cares about that? Enabling services. So we do a lot of services outside. You heard the term here. I don't like using that term, but you've heard the term social determinants of health. I don't use that term. Words are very powerful, communities I come from. So when you say something like determinant, it denotes an inevitability. That if you grow up in East Harlem in the 10029 zip code, this is what's going to happen to you. It is predetermined. And we know that's not right. I'm evidence of that. Right? I grew up in East Harlem, grew up, I often talk about growing up as a Puerto Rican, not a Puerto Rican. We were poor growing up. Medicaid, welfare, the whole bit, one bike between 7 kids, that was our reality. But yet here I stand today, right? And so before they came up with another term called social drivers, you probably have heard social drivers, I was trying to make social influences of health go viral, right? Because it can influence your health, but it doesn't have to determine your health. And so these enabling services that we provide hope to address some of that. We're not housing providers, so we can't address housing, but we provide resources we partner with community-based organizations that do that. So when you come into my exam room and you say, Dr. Aponte, we're living in a shelter, I don't know how to get housing, I got people. I can call folks. And we do it right there in the health center while you're getting your visit, right? So it's that one-stop shop that we do that I think sets us apart. And then again, many of the social drivers, food, we have a food pantry, we have clothing drives, there's a ton of stuff that we do beyond just providing healthcare. We become a place where people even come to socialize, right? Some of my viejitos, they're coming from across the street, they'll sit there and they'll sit in the waiting room. Doña, your appointment is not until 11:30, it's 9 o'clock. Oh, está bien, I just want to sit here for a little while, have my cafecito, and then the staff talk to them, and it becomes part of a social place for them as well. Now that we can socialize again post-COVID, right? So prior, when COVID was going on, it was different circumstances. So FQHCs in New York, so let's drill down. We talked about the national level, what we do national level. So a little, in New York, there are 83 FQHCs that have 850 sites. We take care of 2.4 million New Yorkers. That means 1 in 8 New Yorkers with the population of 19.8 million. I think that's as of 2024. In 90%, again, 200% below the poverty line. And then you'll see there that another 76% are below 100% of the poverty line. Can you imagine a single person in New York City trying to live on $15,000? You can't get a parking space for $15,000 a month in New York. Imagine trying to live off of that, right? So that's the reality of the folks that we take care of. In New York City, again, getting a little more granular, 48 FQHCs with 429 sites, 1.23 million New Yorkers, New York City residents. That means 1 in 7 New York City residents are being seen in an FQHC. So a large concentration. And New York is that sort of, that state of two places, right? There's New York City, and then there's the rest of New York, right? That's how New York, particularly those of us born in New York City, look at the rest of it. But it is very different, right? I mean, you're talking about very urban communities. Then when you talk about, North Country, very rural communities. So different issues, different problems, different, ways that we need to work with those communities. What's our impact? What do we do? Why are we so valuable? You heard some of the stuff that we said there before, but here's some things. So comprehensive services, right? Largely underserved immigrant insurance coverage. It doesn't matter. Ability to pay doesn't matter. We talked about that. We serve as the medical home to many individuals. We're very patient-centered. You guys have probably heard about patient-centered care. Yes, maybe, perhaps, you will soon. Well, patient-centered care is really putting that patient in the middle. As I said, this healthcare system is very complicated, right? And so back in the day, you went to see a doctor, right? This was my experience as a kid. We went to the clinics. And I'm using the word clinic very, very intentionally because clinic in my neighborhood really had a negative connotation to it. When you went to the clinic, you showed up. My mother showed up, usually 4 or 5 of us in tow, because I told you I'm one of 7. So on any given day, there were 4 or 5 of us that needed appointments. She would show up at 8:30 in the morning. No appointment, you just show up. You got there, sit down, we spent all day waiting to see a doctor. No appointments, they saw us whenever they saw us. My mother would get very frustrated. As kids, we were happy because we were running around the waiting room, we were playing, we were out of school, so it was all good. But Then finally they call one of us, not all of us together, right? One at this time, one at another time. It wasn't like they called us staggered or back to back. And then they would bring my mother into the exam room, and of course there were no interpreters then. Right, so what did they do? Who speaks Spanish here? So some random individual, some random stranger now is coming into my space, into my mother's space, to interpret for this doctor that doesn't speak English. Yet this hospital I'm going to, by the way, is in East Harlem. It's Mount Sinai. I could talk badly about Mount Sinai because I got these stitches in the emergency room there, went to medical school there, did my residency there, so I can say what I want about them. But you walk in there, right, and now you have some stranger coming in and sharing intimate details about you, your mother, whoever, right? And so you can imagine, if you just take a moment to think about that, how likely is someone going to share the true details of what's going on with them with some complete stranger that they don't know? But that's what they did. Then, if we spent 15 minutes with the doctor, that was a lot. Gave him a bunch of papers, shoved a bunch of pages in front of my mother, and they were in what? English, of course, right? My mother spoke English, but she preferred Spanish, right? And then maybe I had to go see specialists. How we do that? Figure it out. Make a phone call, right? That is not patient-centered, right? Patient-centered means that we do everything to help you navigate. In our health center, you come in, you get registered, you go into the exam room, you stay there until everything happens, including your blood work, your immunizations, specialty referrals, and when you leave there, you leave with an appointment at hand. So that's what's patient-centered, and FQACs really do that very, very well. Reducing barriers, we talked a little bit about that. We're strategically placed in areas that have high poverty. You're not going to see an FQAC on the Upper East Side. You're not going to see an FQAC in Silicon Valley. We don't exist in those communities because there's no need for us to exist. We have to evidence our need every 3 years to HRSA to say there is a need because there is a shortage of physicians and access to care in certain communities, and there's an overabundance of certain disease burden in this community, and therefore we need to exist. Yes, sir. Yeah, so great question. So for those of you that hear, how do medical records, how do we convey information from one FQAC to a hospital? Nowadays with the electronic health record, it's a little easier, although the interface and the HL7 stuff is nonsense. It doesn't work. Not every EHR can work together, but we have worked on different mechanisms. Depending on our partners, they give us access, community access to the health system, to the EHR, so it's read-only, if you will, and we can upload information. So if I'm sending you, for example, to Mount Sinai Metropolitan Hospital, I, as a community provider, have access to their EHR. I can upload the information into that EHR, and so when you show up there, they see it, right? So it should be smoother than that, quite frankly, right? With electronic health records, it should be seamless. I think that people on Epic, that's one of the big EHRs out here. It's also one of the most expensive EHRs out here. That's like the Cadillac. We can't afford that, right? But Epic Everywhere means that anywhere you go in this country, they can pull up your chart in Epic. But that's not every EHR. And I'm not sure that we'll ever get to that point. You have a question? Yeah.
I was wondering the strategic placement of FQHCs, what data sources that pulls from in terms of like who advocates for where they're placed and what information do they use to determine that? Because I know census data is like important in these cases, but underreports a lot of things in underserved communities.
So great question. So a lot of it goes into that. So usually it's the community advocating for the presence of an FQHC in organizations like ours who are established looking for other areas that need FQHCs. So we look for these communities and some people who have been working in the community as maybe a private provider or Article 28, that's how we license in New York State, may realize that, we want to obtain FQHC status. Then we submit an application to HRSA, depending on, there's funding tied to this, and we submit a ton of data. We submit census data as one, right? That just tells you maybe demographics. We submit all kinds of clinical data. So the burden of asthma, diabetes, pediatrics, the number of healthcare providers in that community, the ratio, the housing situation in that community, the food availability. We do what's called a community health needs assessment. And that community health needs assessment looks at everything, transportation availability, right? All those things impact health. Housing, homelessness. So we put that all into an application that demonstrates that this zip code, this community has a particular need. And then who's in there in that community providing services to the level that we're going to provide. So then HRSA evaluates that and says, indeed, this is a very needy community. They also have data, federal data in terms of health physician shortage areas. So we typically are in areas where there's a shortage of healthcare providers. So that's another piece of data that we emit. It's a huge 90 to 100-page application that we put in to provide data to them to justify our existence. Because there is money tied to this. There is appropriations. Not enough, I would dare say, but that's how it's sort of established. So telehealth, really came into, kind of in vogue, if you will, during COVID. Some of us were doing telehealth, particularly around behavioral health, but then we all had to pivot during COVID and got involved in telehealth. Interestingly enough, while telehealth, I think there's some advantages to it, there are some challenges as well. And in communities like East Harlem, the adoption of telehealth was not that great. People still like that face-to-face interaction. In our communities, we have to build trust. And people are not trustworthy of, technology too much in our community a little bit. They sort of frown upon it. Once you establish a relationship with someone and they get to know you, you might convince them into doing some telehealth activity, but interesting enough, a lot of our patients still like that old school face-to-face interaction that we provide. So some more impact, quality is what we look at, right? And so when you look at our quality scorecards, ours are basically, by the way, our quality scorecards are public domain. You can go into the UDS site for HRSA, federal site. You can look up my health center and you can see how I perform on hypertension control, diabetes control, pediatric immunization, all those data points that people look at. Whereas in private industry, they don't share that. They'll share what they want to share. Ours is totally fully public. And we do as well as, if not better, than many. As a matter of fact, I'm very proud of our health center. HRSA awards distinctions to different health centers. In New York State, of all those health centers I mentioned, only 8, including ours, has what's called a gold badge for quality in terms of what we've done. So we're very intentional on quality. So when people say, are you going to some clinic in the hood? Again, we ain't no clinic. We're a comprehensive health center, right? I share with you all the things that we do. You don't do that in a clinic. Unless you're the Cleveland Clinic or the Mayo Clinic, clinic has a very negative connotation in our neighborhood. So I don't let anybody call us a clinic. Our quality scores really demonstrate that. Again, vital services to these individuals. So remember, I talked about the fact that we take care of 1 in 10 Americans, right? That's 10% of the US population. Yet FQACs only represent 1% of the healthcare dollars spent in this country on a yearly basis. 1% of the trillions of dollars that you guys have heard about that are spent every year, right? The richest country in the world, the highest per capita cost per healthcare. But yet we have proven that we know how to make that dollar go a long way and only spend 1% of healthcare dollars, yet we still have challenges in terms of advocacy for funding for FQHCs despite that all. I'm going to try to speed up because I see our time is going and I do want to allow some changes. So some of our challenges, again, grants, we rely on grants from the government. So when you get a distinction from HRSA, they give you a grant. It's called the 330 grant. It doesn't cover all your costs, but it helps to defray some of our costs, right? So our health center gets about $5 million a year on a $30 million budget from HRSA. So that's a pretty significant part of our budget that without, I wouldn't be able to do all the services that we provide to the community. So, but this funding every year is on the chopping block. It's not hardwired into the budget. Every year we have to go through a whole, going to Congress and rallying around, even though we've always gotten bipartisan support, because remember, FQACs are all over the country, red, blue states, purple states, it doesn't matter, we're there. Yet there's always been a challenge to funding and really sort of hardwiring that funding. It should be hard coded into the budget. Not every year have to go through an appropriations process where there's a debate across the aisle as to how much money to get. So that's something that we actually are challenged. As a matter of fact, January 27th of this year, executive order came out. I was in a conference in New Jersey at LabCorp. Executive order came out suspending all disbursements of all federal funding to all federal fundees, grantees. Can you imagine what that day was like for us? We were like, oh my goodness, what are we gonna do, right? And so fortunately, that executive order was reversed. There was a stay on it, then it was reversed, and so we continue to get our federal funding, but that's a challenge for us, right? And so what I'm thinking about as a CEO is how do I get out from underneath this? How do I become independent enough so I don't have to rely on this federal funding? So this way, anytime someone farts in Congress, I don't have to worry about it. Right, just keep it real, right? That's every time there's an executive order, it's like, okay, what are we doing today? And we do get these enhanced reimbursement rates, right? So I put enhanced in quotation marks because all the things that I do for this patient in one place, that reimbursement rate, as enhanced as it is, still doesn't cover all that. I do care management, I do health navigation, I have a food pantry, I have a clothing pantry. That enhanced reimbursement rate doesn't cover that. Now, I get the same rate regardless of why you come in, and for the providers, the physicians in the room, you understand this, right? You come in, typically, you guys are gonna learn about coding. Are we teaching students about coding? Probably not, right? A little bit? Okay, because we learned nothing about coding when I was a student and a resident. The first time I learned about coding, I got this encounter, remember the encounter sheets? Got this long encounter sheet they had to fill out. I was like, what is this thing full of codes? Now they have these things called ICD-10s, which is like a Bible of all these codes that we submit to get reimbursed for the activity. And intuitively, you think the more resources you put in, so if someone comes in who has hypertension, diabetes, and asthma, and I'm managing that all in one visit, I should get paid more than if someone comes in and I put a Band-Aid on their knee. But yet, under this model, I get the same reimbursement. So on some patients, I'm making out, but on most patients, they always have multiple issues. There's no adult that walks into my health center that doesn't have hypertension, diabetes, and depression. Like, that is like the trifecta of almost every adult that comes into my health center. And then all the other added things that they have. So we're spending a lot of resources to, and this enhanced rate does not cover it. Oh, what I'm doing, okay. Highly regulated, so we report to the city DOH, state DOH, we report to feds. I mean, you name it, we get regulated. We have more audits than you can imagine. Probably the only thing compares to the medical schools when you went through your accreditation, right? Like that kind of scrutiny. But there's all these standards and, from HRSA and from the feds and then from the state and then from the city. And it's just we spend a lot of time just making sure that we're adhering to all these federal regulations, because if not, we risk our funding. Staffing, very difficult. So one of the reasons I accepted this invitation is because I want to plant the seed in this room to FQHCs as a career. And most students, I was talking to your dean earlier, they want to change this for you guys, but most students, and certainly when I was a student, didn't know anything about FQHCs. When you thought about working, you thought about working in a hospital, a private practice, or something like that. You never thought about working in a community health center like this. And what I've also encouraged Dr. Gemeda to do is find FQHCs in this community of yours and have you guys spend time there so you can see firsthand what it's like to work in a place like ours and how you really get a sense of, like, if you went into medicine because you want to make a real difference in someone's life, there's no place more tangible to feel that than in a setting like ours. So that's kind of, but it's not the sexiest job. I get cursed out once in a while, but I know it's not about me. It's about the trauma that patient's facing, right? You take a single mom raising 4 kids in East Harlem, living in poverty. Every day she walks out, she's walking over someone who's strung out on drugs. She's got to worry about taking her kids to the playground because there was a gunfight there last night, and she's worrying about the lights being turned off. Now she comes into my health center, and we want her to behave herself. Right? All she needs is the smallest trigger, and all that trauma is just going to come out, right? It's called trauma-informed care. Hopefully you guys are learning about that, but most times it has to do with that versus what I did to that patient. Now, obviously, if I did something wrong to someone, then I deserve to get cursed out, but most times it has to do with those kinds of things. So attracting people to work in our setting is very challenging because we can't pay the same salaries that some of these academic institutions or private practices do. And so that's a challenge for us. Technology adoption, you know, we're trying to adopt technology, yes. Oh, it's going to exacerbate that. We were just talking about that in the office. I think, you know, what's the average indebtedness now? 300,000, somewhere around there. I mean, that's crazy to leave medical school owing $300,000, right? That's a mortgage. And we're fearful that if you take away loan repayment, then you're not going to get people working in underserved communities. You're not going to get people going to primary care because primary care doesn't pay as well as specialty cares do. I think that's wrong, quite frankly, but, you know, spoken from a primary care physician. But I still feel that, right, that ounce of prevention is worth a pound of cure, and we should be putting more resources into primary care than we do into specialty care. And so it is tipping it. We're seeing it already, right? Everyone's doing a specialty now when they graduate from their residency programs versus just doing primary care. So did I lose? Okay, thought I lost that. All right, so moving along, so East Harlem. So we are the East Harlem Council for Human Services. That's the name of our corporation. We use the name Borinquen because that's one of the programs under our council. The council was created over 60 years ago, founded in 1965. And we were founded, true grassroots effort. A bunch of Puerto Ricans in East Harlem came together and said, what do we need to do for this community? Most of them were maybe as young as, if not younger than you. They were 24-year-old social workers who came together. And they said, what do we need to do our community? At that time, East Harlem, which for those of you from, who's from New York, by the way? New York? New York? Okay, a couple, all right. It's not so bad. And so you know, they really were focused on the living conditions of East Harlem. And there's a, you know, we don't have a lot of time for this, but East Harlem traditionally had a large Latino population, mostly Puerto Rican, starting, you know, 40s, 50s. And then in the 60s, the mid-60s, it had a huge influx of Puerto Ricans because New York gentrified Lincoln Center, which was called San Juan Hill. So San Juan Hill was a big, large Latino Puerto Rican population, but the city at the time, under Robert Moses, you guys should research that guy. People praise him, but he's actually destroyed the way that New York is set up today. And there's nothing to applaud around what Robert Moses did. People think, oh, infrastructure. No, he created divides within community with the Bronx River Parkway and some of the other stuff that he's done in East Harlem. And so one of the projects was to build Lincoln Center in San Juan Hill. And so they pushed all those residents out of there, demolished those buildings, and they pushed them into the slums of East Harlem. And that's where the term slumlords comes from. And so we established these programs, 1968, our bilingual Head Start program, one of the very first fully bilingual Head Start programs. 1974, we created the Borinquen Neighborhood Health Center. Anybody recognize that Borinquen? What does that represent? Anybody? Come on, my Boricuas. What is Borinquen? Right, but what specifically about Puerto Rico? That was the original name of the island of Puerto Rico before the Spaniards came in. The Taino called it Borinquen, spelled the way we spell it, B-O-R-I-K-E-N. A lot of people come in and say, oh, you misspelled the word. I was like, no, we didn't misspell it. That's the way the Taino spelled it. And then the Spaniards came in and named it Puerto Rico, which means rich port. And then you know what the story is from there. That's another lecture for another day. We have a senior nutrition program for older adults. So you can see we do full programs. We go from early childhood all the way to older adults. That's the new phrase, by the way, for older adults. They don't like to be called seniors anymore. Or they can call them recycled teenagers. Those are the two terms they like. And we have a center for them. And bingo is big business in East Harlem. So they come in there, they like to play bingo. We try to do more things than bingo, but they love bingo. And trust me, you can get beat up playing bingo in East Harlem. I went in there one day, I just happened to visit, they were playing bingo. I called out one of the numbers, I did it in Spanish. So, you know, if you know Spanish, 64, 74, very close. I said the wrong word. I said 74 instead of 64 in Spanish, and tell me, these guys almost like ran me out of there. They're gonna jump me. Serious business. And then we have school-based health centers. This is the Borinquen Neighborhood Health Center, so this is our mission. You know, we really are in the fabric of East Harlem, so you see our mission is rooted in a barrio. That's another term that we use to call East Harlem. Spanish Harlem is another term you use. We serve East Harlem and surrounding communities, so we're not only serving East Harlem, South Bronx, and then we have patients who have been to our health center and traveled from other places. And I see we're running out of time, so I'm going to get large Latino population we serve, about 127,000. We're fully bilingual, bicultural. We embrace that. Everything is English and Spanish by default, and then we offer other language interpretation service as well. We serve about 12,000 patients, over 12,000, 60,000 visits a year. And the way I describe our services is from womb to tomb. Everything from the time that a woman's pregnant all the way till the time that, we transition. And we provide all those services under one roof, right? So again, all these services, I'm just going to click away because this is going to take a little while, but all these services are provided by my health center. And if you can see, you see some specialty popping up there now, right? Cardiology, optometry, podiatry. The reason we have those is because we look at the disease burden in certain communities. So East Harlem has a very high disease burden of cardiovascular disease, hypertension. So we put a cardiologist, right? Similarly, optometrists, right? You can get hypertensive retinopathy, diabetic retinopathy. So we have, and then we have podiatry services. So again, we try to make it easy for that patient to navigate. And we know that those services in particular in our community are hard to gain access to. So we're not trying to be specialists, but we're trying to bring those services to our patient. Care management, patient navigation. You guys ever heard of that? So I have a navigator. I have a person who literally will take up one of my patients to an appointment in an Uber that I pay for, so to make sure that they get to that specialist. Oftentimes, these are older patients who are living by themselves, maybe someone who doesn't speak English, someone who's afraid because they just got a mammo that showed a lesion, and now they're afraid to go see that oncologist, so they want someone there to support them. So we navigate them. We actually literally take them there. And our doctors can assign a navigator to a patient. We take them there, they bring all the clinical information to there, and they bring it back to the doctor and bring them back to the health center, right? We do that, and we don't get paid a penny for that. There's no reimbursement for that whatsoever, right? So that's another problem with our system. We may not even be able to answer. And then outreach, we do a lot of outreach, engage with the community, lab services, transportation. I just told you we pay for transportation for many of our patient interpretation services, food pantry, clothing. This is East Harlem, for those of you who don't know where we're located. And I'm gonna go through some of this stuff. But East Harlem, as a lot of folks think about sort of some of the negative things of East Harlem, I like to do sort of asset framing when we talk about East Harlem. East Harlem is a very rich community, culturally very rich, food, music, community. You're not gonna find someplace better than that in terms of that. A lot of resiliency in that community, but it faces issues, right? Because of all the sort of things that have occurred over the history of this country that unfortunately still impact this community. And so these are just some more of the stuff that I love about our community. Demographically, you'll see very large Latino, Latina, depending on how you sort of like to refer to it. I've been schooled on that. Very multicultural. Some of the key features of the community, cultural institutions. So we have a lot of cultural institutions, parks, recreation. Good transit, although still not great. We're still waiting for that Second Avenue subway 100 years later. And that funding just got pulled a couple of days ago because someone had a temper tantrum. And so it has a lot of strengths as well, strong community, local roots. You want great food, come to East Harlem, I'll hook you up. You want some Latino food. Unfortunately, in East Harlem, there's only about 2 truly authentic Puerto Rican restaurants in East Harlem. A lot of Spanish restaurants, but not authentic Puerto Rican like Mom used to make, but still good food. And we celebrate everything as we share. But we got high poverty rates, poor living conditions, high concentration of public housing, which is not always cared for. And then, we're seeing the affordable housing. There is a gentrification going on in East Harlem now. And people are like, oh, aren't you concerned about that? I was like, yeah, maybe. But I just know that, Washington Projects is not going anywhere. Taino Towers is not going anywhere. All these public housings, we have one of the highest density of public housing. They're not going anywhere. And those people are still going to rely upon us. So there's going to be folks who are affluent and they're going to have paying rent, whatever, but there's still going to be a great need for organizations like ours. And then some of the health issues in East Harlem, chronic conditions, we talked about some of them, hypertension, diabetes, asthma. Actually, one of the highest pediatric asthma rates in the country is in East Harlem. South Bronx is another, and then Cook County and Chicago are the 3 highest rates. Obesity rates, for many reasons, right? We talk about food deserts. In East Harlem, very few supermarkets with fresh foods, a lot of bodegas. Nothing wrong with the bodegas, but they tend not to have the freshest foods there, right? And so what do you have to sort of draw upon? And eating healthy is not always cheap, right? And so You know, getting a Happy Meal for $3 for a family that's not making much money, that mother has fed that child. Now, it's not great food, but she's fed the child, right? Whereas trying to find healthier foods. Mental health challenges, and this is something that always was a stickler with East Harlem, right? You know, Latinos, for those of you who know that, don't like to talk about mental health issues, right? They're local. You can't say that, right? But now I think there's been an awareness of people, everybody goes through some mental health issues, no matter who you are. And it's not a condition of being crazy or anything like that. Is that, you know, sometimes you get depressed. Sometimes you can get anxious. And so we've, you know, really opened the door into that. People say, oh, the higher rates of depression, anxiety, East Harlem. No, they've always been there. We just have not treated it, and people have not come out for treatment. It's not that it's all new all of a sudden. And then some environmental factors, poor housing, mold, pets, air pollution in the community, and then the health disparities, which you can read reams of. For every discipline, you can read different health disparities. And then, you know, infrastructure, couple of hospitals there, not big hospitals, but you have a public and private hospital. And then you have several community health centers like ours. So actually in our community, there are 6 FQHCs in 2 zip codes, which is very rare. And what does that say to you? There's tremendous need for that community. So that's why there's so many in that community. And then barriers to access are lack of insurance, language barriers, long wait times. And I'm gonna flip through some of these so we can maybe get, and these are some of the things that we do. Right, so we have events for the community, asylum seeker events. When all these asylum seekers are coming in, we do all kinds of things within the community just to kind of really do outreach. And you know, I can have slides and slides of stuff like that, but we're part of the community. And we feel that we are the place where we're gonna make the difference in terms of healthcare outcomes, right? People closest to the problem are closest to the solution, and we're front line. And this is why I say to you, when you think about having an impact, there's no greater place to have that impact. But there are challenges for us that we need to face. This healthcare system is fragmented. People tend not to work together. We have siloed healthcare system. And what that has done is it's proven over decades that that's an ineffective model to deliver care. We see each other as competitors versus collaborators. And healthcare needs to stop that. And that's something that we're leading in East Harlem with these 6 FQHCs. We're saying, listen, we need to start to work together as a coalition. Create this concept I call no wrong door. Wherever a patient goes, we find services. And if I ain't got the services, I'm gonna send them to you or to you. It doesn't matter. It's about getting the patient to the right place. And that's a fundamental shift that needs to happen in medicine, where you know, people come in to make money in the community. Oak Street opened up across the street from us. If you guys know Oak Street is this, you know, private-owned healthcare organization that focuses on Medicare Advantage patients. They're owned by CVS, so they got billions of dollars, right? They came and opened up 2 blocks away from me. Well, they didn't open up. They were starting to open up. And I reached out to them. I said, okay, so what are you guys doing in East Harlem? What do you hope to accomplish in East Harlem? And why is it that you open a health center 2 blocks away from us and you don't come knock on my door and say, hey, Dr. Aponte, how can we collaborate? How can we work together? If you're here to help improve the healthcare of my community, I welcome you. If you're here to compete with me for dollars, healthcare dollars, then we're gonna make your life difficult because that is failing us. And my commitment to my community is to make sure, I'm tired of talking about eliminating health disparities. How long have we been talking about that? Too long. We need to start eliminating health disparities. And the way you do it is by breaking down these silos, putting that patient in the center, surrounding them with care. Don't worry about who gets paid. There's 127,000 people in East Harlem. There's enough business there for all of us. There's enough margin for everyone, right? Because even though we're not-for-profit, no margin, no mission. We have to make a margin, right? But we don't have to do it at suffering of the community. We can do it as a collective. We can work together, right? And we need to change this model of reimbursement that we also have in terms of how we get paid. If I don't see you, I don't get paid. Yet I have nurses, I have care navigators, I have care managers who are talking to patients on the phone every single day. That's not considered telehealth because they're not a licensed professional. But yet I'm helping keeping those people out of the ER. I'm helping keeping them out of inpatient settings. I'm helping them adhere to their medications. And there's no reimbursement around that because we live in this what's called fee-for-service model of care, right? If I don't see you, I don't get paid. I often say this, fee-for-service is dead. If not, we should kill it. It's not the way to innovate. We should be paid for the quality of the care that we provide, not the quantity of the care we provide. And that's a real big issue within Medicaid. And you'll see when you do that, you actually decrease healthcare spending. And as I shared with you, you saw already, we as FQACs do that better than anybody. We make that dollar go way, way longer than anyone else does. So those are some of the challenges I face. I feel that, there's a great opportunity now. Despite what's happening in this federal government of ours, one thing you should know, first of all, we've been around for 60 years. We're going to outlive this administration. That's number one, right? Everything is being done by executive order. That means the next president comes in, executive order, it goes away. So a lot of people are getting very worried and concerned, and they're doing all kinds of things, It's like, relax. Keep steady. Keep doing the work that we've been doing. Those of us have been doing the work in these communities. Keep at it. And we will continue to help these communities get better. But we can't do it alone. We got to do it as a collective. So I've leaned against our academic health center, Mount Sinai. I've challenged them to do things differently in East Harlem. They have not been great stewards, if you will, of their responsibility to the community of East Harlem. And I said, listen, you guys need to show up differently. It can't be transactional. It's got to be a relationship. You can't just come to me when you need something, like you need research, or you need a letter of support for some building you guys are building, right? Or you need data for some other project that you're working on. You got to be with us in lockstep. And then Metropolitan Hospital, City Hospital. So we have that opportunity. And what I said to both of them is that if you guys don't do it, I'll work with whoever is going to take care. I'll work with Hackensack Meridian. If you guys want to come into East Harlem and work with us and help us in our community, I'll work with them as well. Whoever's going to help us do the work that I think needs to be done. And so that's something that, I'm focusing on, the sort of last leg of my race in this career of mine, because I'm not trying to do this forever. But I think there's a way that we can make a difference in these communities. And hopefully you guys will consider joining the movement of FQHCs and seeing the work that we do firsthand. So I'm gonna stop there. I know I went over time. I do apologize. There's so much more I want to share with you guys, but we definitely ran out of time. But I want to thank you guys for your time and attention. I want to congratulate you again for being in where you are. Think about your why. Always remember your why, and you'll do well. Always chase that dream, not the money. The money will follow you. I tell my son this all the time. I said, find a passion, do something well, and people will pay you to do it. But I've never chased a paycheck in medicine. Having said that, it's good to get paid well for what you do. All right? All right, thank you guys very much. So,
Well, thanks so much for that. And above all, thanks for all you're doing. I mean, what a message for all of us about how you care and how you bring humanism to medicine and your whole community. So,
thank you.
That is the biggest takeaway. Just wondering, and, reading a lot and hearing about, all this increased ICE activity and how people are afraid to seek healthcare, and that visits of people who need it, they feel like they can't do it.
Yeah.
Are you creating, and how are you dealing with it?
Yeah, no, great question. Thank you for answering that question, because that is actually something that has really changed a lot. And in our community, while we do certainly in East Harlem still have a certain undocumented immigrant population, and about 2 years ago, when there was a mass sort of influx of asylum seekers across the border there from South America, we got a lot. Most of our residents of East Harlem are, documented individuals. However, we have seen individuals not seeking care, particularly some of my colleagues that live in areas like Long Island, where you have a larger immigrant population there, where they have seen double-digit decreases in percentage decreases in people coming to seek care, and they're actively trying to reach out to them, and they're saying they're afraid to come in. As a matter of fact, one of my colleagues who runs a health center in Long Island had ICE in his parking lot waiting for patients to come out. I've had to do, you guys have heard of emergency preparedness, right? Right, we run fire drills, we think about active shooter, all that stuff. I have had to do a drill in my health center, what to do if an ICE agent comes into our building. They're not supposed to come into our building, right? Healthcare facilities, schools, they're not supposed to, but they're not supposed to do a lot of the stuff that they're doing right now, right? And they're still doing it. So we've had to really educate our staff and our patients about the safety that we would provide them if they do come seek healthcare for us. And that's where telehealth can play a role as well for those who are afraid to come in. As you know, we can only do but so much through telehealth. There's something that of laying of hands, right? That's what we do as providers. And so it has had a significant impact for a certain population. And worse is now, As I told you, it doesn't matter your insurance status or immigration status, we see everyone. Well, there was an executive order that came out 2 months ago, I forgot which one it was because I lose track of them, that stated that they try to have a reinterpretation on this, this law back in 1992. It's called PIRORA. And it has to do with evidencing whether or not someone's a citizen before you provide services that are funded by federal dollars. And in 1992, they said it is allowed to do that for certain individuals. They can get resources and services even if they're not documented, they have certain statuses. Now this administration wants to do away with all that. And they want us to ask, we don't ask anybody what's your citizenship when you come to see us. We don't ask you that question, right? And so now they want us to, and we're unfortunately, fortunately that has again had to stay and it's not being implemented, but that's going to impact a large number of undocumented individuals who normally would be seeking care with us, right? It's very short-sighted because you know where those folks are going to go, right?
ER.
They're going to go to the ER. And so the ER costs are going to go up. So you're not saving anything by doing what you're doing here. You're going to be paying for this one way or the other. And go ahead and send them the bill. Send them the bill. See if you can get paid for it. You're not going to get paid for that. So you're providing diabetes primary care in the emergency room. How expensive is that compared to an outpatient setting? So it's very short-sighted.
Thank you.
Other questions, comments, concerns, criticisms, I accept them all. Yes. Yes. We see anybody who comes to our door, it doesn't matter. I mean, technically, you can even come from another state to come see us. But, you know, if you want to cross the bridge, holler at me. But yeah, anybody who walks in, you don't have to be in our catchment area. We do have a catchment area where, 75% of our patients come, and they tend to be around our area, but technically they can come from where. And like I said earlier, we have patients who know us, moved away from the community, but trust us and still come from like Far Rockaway, Queens, Brooklyn. They still come to see our health center. Is that a question or is that? Yes. And I got my Yankee fan over here.
Yeah, I was wondering where the patients get their medications after they see the doctors at your place, because patients with chronic conditions, they probably need medications for,
So I probably flipped too quickly. We have a pharmacy.
okay.
Pharmacy in our health center. So you leave, you go downstairs. Before you go, your prescription is waiting for you right down there. And it's under we also have what's called the 340B program. If you're familiar with that program, it's a program where we're allowed to get medications directly from the manufacturer at cost. And then we provide it to uninsured and underinsured patients at cost with maybe $1 or $2 margin on it, right? So you imagine someone who has no insurance or they have high, co-pays or deductibles for the medications, they can utilize our 340B pharmacy and get the medication at a reduced cost. And it's right there. We deliver to the 5 boroughs. We do blister packaging there as well for our elderly patients on polypharmacy. So we make it one-stop shop. I'm sorry you missed that in the slide, but that's definitely a service that we provide as well.
Thank you.
Question, you mentioned earlier in the talk, you alluded to some of the changes in HR1 that are affecting the healthcare system broadly, but in particular, some of the services you provide. Obviously, a lot of the political debate and conversation, even now with the government shutdown, has been talking about Medicaid and the changes to that. Obviously, in the medical school side, we're worried about our future classmates who the federal student loan availability has been shrunk. So that gets to the beginning of your talk. But what in particular, have there been any changes in that bill that impact FQHRs?
JCs.
Yes, impact those in particular? And if so, what changes are you doing to adapt to those?
So the biggest issue for us in HR1 is the cuts to Medicaid. So there's an $8 trillion cut to Medicaid over the next 10 years. They're trying to get more people off the Medicaid rosters. They're eliminating some individuals in some states like New York who are insured under Medicaid, what's called the Essential Plan. I'm not sure what they call it in Jersey, if they have the same name for it. But these are individuals who are living in poverty, have a certain status, and are able to get Medicaid dollars. They want to eliminate that totally. They're also making it more difficult to apply for Medicaid. In New York, recertification is every year. During the pandemic, they forestalled it for several years, right? You have to re-enroll to Medicaid. Now they want to make it every 6 months. Think about the people who are on Medicaid. Now, a Medicaid application, it's not rocket science, but it's about 12, 13 pages long of information. And if you imagine if you're English as a second language, literacy issues, how do you do that every 6 months? And then the other provision is a work requirement or school requirement. So now they're requiring individuals to work or go to school and evidence that at least 80 hours a month. That's a part-time job, right? So those things, we're afraid because of this recertification in particular, because East Harlem has a much more traditional Medicaid population of people who are residents and you know, documented individuals. But we think that recertification piece and that job requirement piece is really going to affect them. And then for children in New York State, they had continuous enrollment in Medicaid for the first 6 years of life for obvious reasons, right? You want to make sure kids, right? And I'm not just speaking as a pediatrician. I think any of us who are parents or whatever understand that those first 6 years are critical to that child's well-being for the rest of their lives. And so it's important that they always have access to the healthcare that they need. And so in New York State, any child who got on Medicaid, you stayed on Medicaid for 5, 6 years before you had to recertify. Now they're making children have to recertify. And then finally, pregnant women. So in New York State, all pregnant women, regardless of your immigration status, were automatically enrolled in Medicaid. That no longer will be the case, which means women will not be getting prenatal care. That means women will be having worse healthcare outcomes. And of course, it's going to be our Black and brown women, as usual, who are going to be disproportionately impacted by that. So those are, I mean, that's the biggest issue of many issues with HR1, but that's the biggest issue that impacts FQHCs like ours. And thank you very much. Yeah, SNAP cuts as well. So food, right? I mean, Head Start is being, I told you, we have one of New York City's oldest Head Start programs. We've been running that program for 57 years, fully bilingual. This year, there was an RFP. You have to seek funding, right? Request for proposal from the feds. They have not funded Head Start. So this year, my program that has been around for 57 years is being funded by New York City, but come June of 26, I don't know where the funding is going to come from. Can you imagine eliminating Head Start in this country? Like, there's no doubt about the impact of Head Start. Like evidence over, I mean, there's reams of data that demonstrate that children who go to Head Start do much better in terms of school preparedness. Not even to mention how it helps parents who perhaps want to work. Where's childcare issues for these people? It's hard to find childcare, and if you do find childcare, it's very expensive. So programs like Head Start are also being impacted by this bill. So it's a multitude of different things. You know, I'm not sure if you're a fan of Marjorie Taylor Greene, but she said the other day that her 2 adult children are going to have double increase in their premiums because of this bill. Well, you should have thought about that before you signed the bill, right? That's what's happening with this bill. Yes.
Comment and a question. So
this young person here, we have a history together. You want to tell them who you are and how we know each other?
so I know everybody in this room, but I don't know who's online. So this is Ofelia Martinez. For those of you on Zoom, I don't know who you are. And one of my comments was actually going to follow up your very strong urgency to our learners in the room to actually consider a career at an FQHC. I actually started my career, first job out of residency at an FQHC in East Harlem. And guess who was my hiring chair for my first job out of residency. So Dr. Aponte actually hired me from the emergency department.
I saw talent and I grabbed it.
There we go. And I have to say that it was actually a very transformative time for me as a young physician, understanding patients, understanding what they needed, understanding what patient-centered care was really all about. And so I could not actually endorse it anymore. It was really such a valuable experience, and one that a lot of the curriculum, actually funny, we've written so many different cases. You know, what brought me here was our mission for our school, very squarely focused on health equity and, you know, in New Jersey and everywhere. And sometimes our students actually engage with cases that I have written and look at me and say, Dr. Martinez, you have a wild imagination, right? Like those cases that can't possibly be true.
Oh.
And this is people's real lives, right? You know, we take a lot of that kind of pulled from real life. So really important. So sorry to go on and on about that, but
No.
I can't actually overstate that.
Thank you.
And
Good to see
no,
you.
thank you.
And congratulations on your career as well.
Well,
So,
thank you. I've been very fortunate to land in this wonderful place with wonderful people and lots of support. So thank you.
all right, you heard that, Dean?
And students. So I guess bringing it around to my question, right, is actually getting back to medical education, right? We talk a lot about how to care for patients in the most patient-centered and humanistic and effective, high-quality fashion. And that really begins when the students walk in the door. Right? Unfortunately, I don't think it's going to change anytime soon that people who matriculate into medical school don't mimic our general population. And so what we have to teach the students to be able to understand our patients is very broad ranging. And the most important thing we can teach them is the impact of how their interactions matter and what patients actually need. And you've talked a lot of that from the practice perspective. I'm wondering what would be your kind of prioritized suggestions for how we actually provide that high impact message and deliver that earlier on in med school.
Yeah, thank you for that question. And again, good to see you. You know, I think that this is why I did some of the work that Dr. Gameda and I did in terms of really diversifying the medical school class, right? Because these lived experiences are a benefit to your colleagues. Right? So when Ophelia is talking about these stories that she's sharing and people think that these are fabricated, made up stories, these are lived experiences that we've had. And how do you get that experience into the classroom for those individuals who are not exposed to no fault of their own, right? And so this is the value of diversity, right? And despite what people think in terms of what their connotation of diversity is, this is why diversity is important in every institution. So that you can have that perspective and you can talk to someone like Ophelia and myself and say, what was that like living in East Harlem? What was that like living in these conditions? And tell me how your community interacts with you in a certain way. You're not going to get that unless we're in that room to share that experience. And then getting you guys out into the community, obviously, right? As early as possible into settings like ours so you can start to see that for yourself and be around that and be open to that, right? And, you know, we're not the experts in every single culture out here, but the more exposures to different cultures, different people, different perspectives, right? Culture is the lens by which everyone, so I'm gonna put my cultural competency hat on at McBee. I used to do a lot of these lectures actually around this as well, but culture is the lens by which everyone sees the world, right? And so you need to understand what that lens is. And the way you understand it is by talking to people who have that lived experience. And so the more exposure you can get to that early on in your career, I think that's gonna augment your career no matter where you wind up practicing. It's going to be a tool in that toolbox that you're sort of putting together as students. And so I think those two things alone can have a very significant impact. There are threats to the former, right? Right now you can't even have a diversity office now because everyone's attacking it. Now, when we first started this work, I mean, way back when, the goal was that you eventually would not need a diversity dean, because if it's embedded in the culture of the institution, where everything that we do, everything that we look at, we look through that lens of diversity, then you wouldn't need an individual to spearhead that effort. Unfortunately, some people have adopted that better, some institutions have adopted that better, and some have stayed way far behind, and some have reversed course, quite frankly, on it, right? And so that's the unfortunate reality of it. But whatever you want to call it nowadays, there's still a value. You guys should be promoting it amongst your own class. We became big recruiters at Mount Sinai when I was a student there. I won't tell you the year, but I'm proud of my age actually, but it was a long time ago. But there was very little diversity for a school located in East Harlem. Right? We were 5 students out of a class of 105 that were people of color. And I was like, that's outrageous. And we became active as students to recruit others because we knew the value of that. So I think all those sorts of things together, you know, will help with that perspective. And it's to your benefit, everyone's benefit. White, brown, black, I don't care what skin color you are or how you identify. Everyone benefits from diversity. Any other last minute questions? All right, well, anyway, thank you again, guys, for the time, appreciate it. Don't forget to fill out your surveys. No, I'm just kidding.
Yeah,
Thank you so much.
fantastic.
Nice
What a
to
great
meet you.
message,
Thank you so
and
much.
really
Appreciate it.